For decades, cannabis has been framed as safe, natural, even therapeutic. It treats nausea, it stimulates appetite, it calms the nervous system. But today, millions of people are discovering a paradox. For some chronic users, cannabis stops calming the system and starts breaking it. This condition is called Cannabinoid Hyperemesis Syndrome, or CHS, a disorder where the same substance used to prevent nausea begins to cause uncontrollable vomiting. Not from overdose, not from contamination, but from long-term biological adaptation. And to understand CHS, we have to stop thinking about cannabis as a drug and start thinking about it as a systemic signal that rewires the body over time. A key question in understanding CHS is the underlying cause of its development. Scientists have studied an in-depth exploration of the pathogenesis of CHS. Cannabis contains over 100 different cannabinoids, with delta-9 THC and CBD being the primary compounds. These cannabinoids bind to cannabinoid receptors type 1, CB1, and type 2, CB2, which are distributed throughout the body. Specifically, CB1 receptors are primarily located in the brain, while CB2 receptors are found outside the central nervous system, CNS, in areas like the spleen, thymus, and other immune cell populations. THC, the principal exogenous cannabinoid in cannabis, is metabolized in the liver through oxidative and hydroxylation reactions by the CYP2C enzyme subfamily. THC is known for its antiemetic properties when it binds to both CB1 and CB2 receptors. The half-life of THC ranges from 20 to 30 hours, though this can vary depending on the cannabis product. THC is excreted in feces, around 60 to 85%, and urine, around 20 to 35% as acid metabolites. Due to its lipophilic nature, THC accumulates in adipose tissue over time. This storage creates a reintoxication effect, where stored THC can be released under conditions such as stress or prolonged fasting. Chronic cannabis users tend to have significant THC reserves in their fat tissue, which can be mobilized during stressful situations. Other cannabinoids, such as CBD and cannabigerol, CBG, may also contribute to the development of CHS. At low doses, CBD is known to be antiemetic, but at higher doses, it can become proemetic. CBG has the potential to reverse the antiemetic effects of CBD, suggesting that CHS could result from the interplay between high levels of CBD and its reversal by CBG. The susceptibility to CHS may also be influenced by cytochrome CYP450 metabolism and genetic polymorphisms. Variations in genes encoding enzymes like CYP2C9, CYP2C19, and CYP3A4 can lead to an excess accumulation of cannabinoid metabolites, potentially triggering vomiting. THC is primarily metabolized to two major metabolites, 11-hydroxy-delta-9 tetrahydrocannabinol, 11-O-HTHC, and 11-nor-9-carboxy THC delta-9 tetrahydrocannabinol, THC-COOH, along with over 100 minor metabolites. 11-OH-THC is psychoactive and shares similar potency to THC, whereas THC-COOH is non-psychoactive and has anti-inflammatory effects. If the endocannabinoid system gets disrupted by excessive use of cannabinoids, the stimulation of the hypothalamic pituitary adrenal HPA axis and the sympathetic nervous system may occur. Stress is regulated and controlled partially by the endocannabinoid system and the HPA axis is the main neuroendocrine system activated by the stress response and therefore cannabinoids. The HPA axis and sympathetic nervous system must balance their roles to mediate the stress. The response to stress is important in survival, but long-term stress can have negative effects on one's health. Endocannabinoids play their part in allostasis by promoting recovery from stress and further bring back homeostasis of the neurotransmitters, neurohormones, and neuropeptides. CHS is defined by recurrent cycles of severe nausea, intractable vomiting, abdominal pain, dehydration, repeated emergency room visits. What makes it clinically confusing is that standard anti-nausea drugs often don't work. Ondansetron fails. Metoclopramide fails. Patients keep vomiting anyway. One behavior shows up again and again: compulsive hot bathing. Patients will take scalding hot showers for hours, sometimes the only thing that provides temporary relief. This isn't psychological, it's neurobiological, and it's one of the strongest diagnostic clues clinicians have today. Patients with CHS frequently exhibit a unique compulsive behavior with multiple hot baths or showers that commonly provide temporary symptom relief. One of the first few reports of hot water bathing was by a case series of 18 patients who had recurrent episodes of vomiting and chronic cannabis use. Though this hot water bathing pattern was thought to be pathognomonic of cannabis use and CHS, the unique bathing behavior has also been reported in 50% of patients with CVS who do not use cannabis. Hot water bathing behavior has been reported to result in marked, albeit temporary, improvement in nausea, vomiting, abdominal pain, and symptoms associated with panic. Symptoms often return within 10 to 30 minutes after hot water bathing, which might explain why patients take up to 20 hot showers a day or sit in a hot bath as long as possible. In extreme cases, patients will even resort to checking into a hotel to ensure a continuous supply of hot water. Compared with occasional cannabis users or non-users, regular cannabis users, greater than 4 times per week, are more likely to use very hot water and remain in baths for longer periods of time to feel the relief provided by the hot water. Furthermore, regular users were noted to have a higher burden of GI symptoms and more anxiety compared with occasional and non-users. About 4% of patients that present with hot water bathing behavior can even sustain burns, called erythema abigne, as a result. This hot water bathing behavior in CHS is not understood, and how it contributes to improving symptoms is unclear. The ECS is recognized to be engaged during response to stressful stimuli. An increase in endocannabinoids occurs within several minutes of exposure to the stress, and usually returns to the baseline value within an hour. This data leads to the hypothesis that hot water exposure may relieve the symptoms of nausea and vomiting because of increased endocannabinoid release and the subsequent activation of CB1 receptors. However, to the best of our knowledge, no one has examined the effects of hot water exposure on endocannabinoid levels. In addition, proposed mechanisms include increased core temperature via effects on CB1 receptors in the thermoregulatory centers in the hypothalamus, skin vanilloid 1 receptor stimulation, and blood flow shift from viscera to skin. A second target is the TRPV1 receptor, also known as the capsaicin or vanilloid receptor. The TRPV1 receptors are distributed in various parts of the gastrointestinal tract and vagal afferents that innervate the stomach and intestine, and are also distributed in the enteric nervous system. Those receptors are activated by heat, temperature greater than 43 degrees Celsius, and capsaicin, and by high concentrations of anandamide. This suggests that hot water bathing does not act via TRVP1 receptors, which will require scalding temperatures. Thus, we speculate that mobilized anandamide could initially activate but then desensitize TPRV1, resulting in widespread symptom improvement. Understanding the mechanisms and specific characteristics of this hot water bathing pattern in CHS will help determine the pathophysiology in CHS and CVS, potentially aiding in the development of targeted therapies for these complex entities. CHS develops in 3 phases. 1. Prodromal phase. Morning nausea, mild abdominal discomfort, continued or increased cannabis use. Symptoms often dismissed. 2. Hyperemetic phase. Explosive, cyclic vomiting, inability to eat, severe electrolyte imbalance, hot showers as symptom control, frequent ER visits. 3. Recovery phase. Only occurs after complete cannabis cessation. Symptoms resolve over days to weeks. Many patients relapse and restart the cycle. Crucially, reduction isn't enough. Switching strains doesn't work. CBD doesn't reliably fix it. Only abstinence resets the system. The endocannabinoid system, ECS, regulates gut motility, nausea control, temperature regulation, immune signaling, stress responses. Cannabis floods this system with exogenous cannabinoids, especially THC. At low or intermittent exposure, THC is antiemetic, but chronic, high-frequency exposure flips the signal. Here's what happens. CB1 receptors desensitize. Gut motility becomes dysregulated. Nausea circuits in the brainstem become hyperreactive. TRVP1 heat receptors become overinvolved. This explains why hot showers help. Heat activates TRPV1 receptors, temporarily overriding the broken nausea signal. You're not treating the disease, you're hacking around a malfunctioning neural circuit. Here's where new science changes everything. Recent transcriptomic studies show that CHS is not just neurological. Blood RNA sequencing reveals upregulated B-cell immunoglobulin genes, altered T-cell and monocyte signaling, increased HLA class 1 expression, restricted HLA class 2 allele usage, markers consistent with allergic hypersensitivity. In plain terms, CHS may be an acquired immune hypersensitivity to cannabis localized in the gut, not inherited, not immediate, acquired over time. This reframes CHS as something closer to a food allergy, a drug-induced gut hypersensitivity, an immune-mediated barrier failure. The gut lining shows signs of impaired adhesion and increased permeability, allowing immune activation to spiral. Cannabis becomes the trigger, not the toxin. Average time to diagnosis, 3 to 6 years. Why? Cannabis is assumed to be anti-nausea. Patients increase use when symptoms start. Labs and imaging are often normal. Providers rarely ask about cannabis patterns. Even today, only about 11% of people with CHS symptoms report receiving a formal diagnosis. That means millions are suffering without a name for what's happening. Delayed and/or misdiagnosis and treatment can lead to increased frequency of seeking care in the emergency department or increased number of hospitalizations with their consequent economic impact. National data now shows approximately 15% of U.S. adults report daily cannabis use. Approximately 17.8% of daily users report CHS-like symptoms. That's over 7 million Americans. CHS is now the most common cannabis-related cause of ER visits. Legalization didn't create CHS. Idiots cosplaying as Snoop Dogg and Wiz Khalifa did. Right now, acute relief, haloperidol, capsaicin, IV fluids. Long-term cure, cannabis cessation. But emerging research points to future directions. Immune biomarkers for early detection, HLA-based risk stratification, gut-targeted therapies, TRVP1 modulating treatments, induced tolerance strategies. CHS isn't a moral failure. It isn't a weakness. It's biology adapting past its limit. Cannabis isn't harmless, and it isn't evil. It's powerful. And when a powerful signal is pushed too far for too long, that system breaks. CHS is the body saying, this pathway is saturated. Understanding that isn't anti-cannabis, it's pro-biology. And awareness is the first treatment.